Welcome to MedAxiom HeartTalk, where thought leaders come together for one ultimate goal: to continually transform cardiovascular care for all. MedAxiom HeartTalk starts now.
Hi, I'm Melanie Lawson, host of MedAxiom HeartTalk, and today we are having a conversation about finding solutions for CV care in rural America. And today we have a fantastic team of experts to discuss this. We are joined by Frank Briggs, Vice President of Heart and Vascular Service Line at WVU Medicine. Also, Dr. George Sokos, Professor and Chair, Department of Cardiology, also at WVU Medicine. And then Jenny Kennedy, Vice President of Care Transformation Services at MedAxiom. Thank you all so much for joining us.
Great to be here.
Thank you.
You know, let's talk about folks who live in rural areas. Sometimes it is so difficult for them to get the proper care and the follow-up care as well. So let's talk about some of the biggest challenges specifically for cardiovascular care in rural areas.
So I'd say probably our largest challenge is access to care. We're a relatively, large health system, 25 hospitals, a lot of critical access hospitals, most of which do not have cardiologists on site. So finding access to care in a lot of the areas of the state is extremely difficult. We know that's not unique to West Virginia. That's a problem that's felt nationwide. Over 40% of counties in the United States don't have a cardiologist.
Yeah. So how do you connect the patient to the cardiologist when you have that kind of distance being an issue, or even having access to a vehicle to get there?
So one of our challenges is obviously geography, being a very mountainous state, in the mountain state. Moving patients is very difficult. So we often will move the provider as an alternative to the clinic site once a week, once a month, depending on the need and volume. Rather than having all those patients driving 3 to 4 hours for care.
Mm-hmm. Yeah, because you said it might look different closer on a map, but when it comes down to it, that travel
Absolutely.
time is really an issue.
Right, and internet access is a significant issue for us. The infrastructure is not there. Access to broadband is very difficult for a lot of our patients. Either it's not there or they can't afford it. Mm-hmm. So we often have patients that will go to Sheets. I don't know if you've ever heard of that. It's a pretty large gas station chain, mm-hmm. Along in West Virginia and really the East Coast, that they'll utilize their internet to have video visits with us. So it's challenging.
That is hard. I mean, especially you're in a gas station talking about private information. Jen, do you have any thoughts on this?
Yeah, I would say, the need to physically be somewhere for even providers now. So depending on the infrastructure and what the community has and is available, we don't physically have to be there anymore too with some of our technology, so we can leverage team-based care. So if you have a clinic and a patient needs to be seen in person, you can have an APP facilitate an assessment and remote in the physician. So that's a great option for some of our heart failure patients and our specialties where those physicians can't be everywhere that the need is. And then leveraging our remote technologies, there's so many options now that we can really tailor it based on what your community needs and what is available in terms of, like you said, the internet, transportation. So it can be individualized as well.
Yeah, gentlemen, do you all have any other thoughts on maybe how to overcome these solutions and also remaining cost effective while doing so?
Yeah, we absolutely utilize mid-level providers to really bridge that gap, not only in conjunction with us, but we've provided a lot of training. So we'll often bring the providers to us to main campus, train a nurse practitioner or PA to be able to care for those patients, so that not only can they do that in conjunction with us over a video visit, but they can do it on their own. So we feel it's really important. Education is a key piece of the puzzle when it comes to improving access.
I'd say where we can't do video visits, we supplement a lot of phone calls. Okay. So you can still do the phone call, get a lot of that communication, those points across, even without having that face-to-face on the video.
Right, by any means necessary, making sure you're serving those patients.
Yeah, and I think that's one thing that we were, recently at the ACC Legislative Conference advocating to maintain, the capabilities of telemedicine. It's really important, and I think that's something we all need to continue to push for.
Definitely. So no one gets left behind.
Agree. I think we did a really good job with COVID. It forced us into that space, but we have seen trends where, COVID is not a priority or an issue as much, and we've let our foot off the gas a bit, especially in cardiology. And I think it goes back to that right patient, right care, right time. And as Frank said, there's no reason a phone call isn't adequate for certain visits and certain conversations. So we do need to be able to offer various levels of care for what the patient needs and be able to be reimbursed appropriately. So I hope that we can get that back on, and we're going to have to continue to be successful and meet our community needs.
Yeah, there were a lot of things that worked, during the pandemic that we were forced to do very quickly that should still remain. Can you share maybe a specific example of how putting these strategies into place really improved a specific patient's outcome?
We have a hospital in southern West Virginia, almost over 4 hours away, where we've been able to really start heart failure care. I'm an advanced heart failure cardiologist. Obviously, there's not an advanced heart failure cardiologist in the southern part of the state at a small hospital, so we're able to provide those consultative services on site. And even some of the times the patients need to come to us, we can bridge that time period when there's not a bed for them to get to us to care for them in place there until such time they can come to us. So there's several patient stories like that really pick one. It would be difficult, to be quite honest with you, because we do that pretty much every day. And that's, we really, I think, have done, a nice service to our patient population by doing that.
Yeah, you're forced to be creative.
Yes.
Yeah. Yes. So how are you working with communities to enhance cardiovascular care?
Yeah, so that's a great question. I think we've partnered with multiple areas of each community, from community healthcare workers to our most recent project is with community pharmacies. In West Virginia, there are more community-owned pharmacies per capita than any other state in the United States. And so we've created a program to train our community pharmacists with respect to heart failure and recognizing heart failure medications and better understanding heart failure care, and so that they're able to work with their local physicians and with us to help provide better services. And it's been really useful, and I think we just started this, so really to see the outcomes we don't know yet, but I know that it's going to be an important thing for us.
Mm-hmm.
I think when you look at many of these communities, the pharmacist may be the only healthcare provider in that community. So involving them and including them early in the process has been very important. Will continue to prove helpful.
And it sounds like you're using all the resources, because pharmacists are very knowledgeable a lot of times. So using those resources in the appropriate way.
Absolutely.
That's what I would say. I think that's such a great idea, because a lot of times we get so kind of into our own vision and say, we have to figure this out. And there's so many great resources. You have to do a little research and a lot of conversations, but you can find people who are trying to tackle the same issues. And huge fan of pharmacists, especially with our heart failure medication and guidelines. They're really champions, and so that's great. I look forward to hearing how that goes.
Frank and I are huge fans
Yep.
of pharmacists. We're both pharmacists. We're both married pharmacists, so our bosses at home are pharmacists as well, right? So,
And every rural community is different, right? I mean, and so it sounds to me like trying to tap into finding what are the resources in that particular community that you all can work with.
And we don't necessarily have to own the entire care team.
Mm-hmm.
It's really how do you use all those resources.
and we don't want, I think that's important. We don't want to own the entire care team. We want to partner with communities. Everything doesn't have to be under WVU Medicine. We as long as we're working together, that's a dietitian, local farmers, anything like that to get healthier foods and those choices. We do a lot of that already, and we really feel that those partnerships are essential.
Let me ask, how do you kind of start that process? Because if you're not doing that, I mean, that really is the buy-in and tapping into who can do what and then getting them involved.
So I think you have to talk to your local physicians, or any part of the care team. Say who lives where, because if it doesn't come from within the community, it's not going to happen. I think we work with churches a lot, obviously, but it doesn't have to be only faith-based. There's lots of other opportunities in the area, and local chamber of commerce, those sorts of things. Understand what's going to work in that particular community. It doesn't just it shouldn't all come from us as a health system. We can provide the resources and the knowledge, but the understanding has to come from the community.
All right. Well, thank you all so much for talking about this, a really important topic. I think that every patient matters. And clearly you're doing the work so they get seen and the proper help that they need. Thank you so much.
Thank you.
Thank you.
you.